Jar Oil. The company have filling stations across the country, and our rates are relatively cheaper than anyone else across the country. Jar Oil is the biggest producer and distributor of cement in the country with the most competitive prices in the market.
Axel jam si Wave.
Yo, Abla, yo, luta to dede. Luta mo nulo jel mo to nga andil mahalis. Hello?
Busel mo fine.
What?
Busel mo fine.
Oh, yes!
Wave Axina Gambia. Deposit and withdraw money, pay bills, and buy mobile credit without fees. Transfer money wherever in the country for only 1% fee. At Wave. Busel mo fine? Wave. Your money is yours.
It's Monday, the 13th of October, 2025, and live on West Coast Radio, you're with Coffee Time with Peter Gomez. Now, October is globally recognized as Pink October, hence the reason I'm in pink this morning. It's a month dedicated to raising awareness about breast and cervical cancer, but here in the Gambia, it also offers a broader opportunity, a moment to shine the spotlight on other pressing health concerns that often go unnoticed. Thanks to the partnership of Comium, West Coast Radio is turning its lens this morning towards the country's wider health landscape because health awareness shouldn't be seasonal. Later in the program, we'll talk about mental health. But first this morning, we focus on epilepsy and brain issues with our two doctors from the Gambia's main referral hospital in the capital, that is the Edward Francis Small Teaching Hospital in Banjul. We'll start with the introductions. And first up, actually the first of the two doctors who was here this morning.
Okay, my name is Ndobisi Uwezuoke. I'm a consultant pediatric neurologist, so I manage brain disorders in children.
How do they call you for short at the hospital?
I'm called Ndobisi.
Just Ndobisi. Ndobisi.
And if it's too difficult, ND.
ND. I'll try Ndobisi. All right, you're welcome. Yes. Doctor?
Thank you so much for having me. I'm John Nud Jabang. I'm a senior consultant in neurosurgeon at the Edward Francis Small Teaching Hospital. And by subspecialty too, I'm a pediatric neurosurgeon. And I'm glad to be here. Thank you.
Okay, we're going to be focusing on epilepsy and brain issues. But of course, given the month we are in, we cannot start without, talking about breast cancer and Pink October. In the earlier program, we spoke about, signs and symptoms. Let's talk about human cost. I mean, what is the impact of breast cancer on families affected by it? If I may start with you, Dr. Ndobisi.
Well, the first is you see people who you used to know who were whole. First, their minds are eaten up by the disease, the fear of death, the alarm that they have the disease, then the issue of watching them move from being normal to being lifeless, then watching the challenge, the fear, the panic, the convulsions when there's metastasis to the brain, and all those things, it distorts families. Above all, the cost is enormous. And I had a friend whose wife had it and died from it. He's a consultant cardiologist. And I know that all the money we were able to pull together to buy the drug, because she had a problem, metastasis to the brain, and made her drink up to 50 liters of water a day. And then all the money we pulled together to buy the drug, even when we bought the drug, it was too late. She still died. So it's a very traumatizing thing. But above all, I think the message is that it's preventable and we can detect it early.
And in terms of management, still talking about cost, how difficult is it to, treat breast cancer and cervical cancer? Let's look at the two together. Dr. Jabba.
Yeah, so thank you so much. Just let me say a disclaimer. We are neurosurgeons, so we would not be really perfect in trying to manage that. But again, just looking at it from a doctor's perspective, so all cancers now, the treatments have various stages. there is, of course, the surgical treatment, which is the removal of the tissue itself, the cancerous tissue itself, both cervical and the breast. And also, because they are cancers and they spread, and before you notice it, there is a lump, but it's spreading within the broad stream. Dr. Ndubusi was talking about metastasis to the brain, meaning that the cancer can spread to the brain, and that's basically when we come to see those patients. But it can also spread to the bones, it can spread to the it can spread to every part of the body, and therefore it needs other treatments that are added to it, which we call adjuvant therapy. Those adjuvant therapy obviously include things like chemotherapy. Also, they include things like radiotherapy. Now, you're talking about how hard it is, especially bringing it to the Gambian context. Chemotherapy medications are very hard to come by. The chemotherapy medication itself has a lot of side effects. You see sometimes people are on chemotherapy medications and, all their hair is gone. In fact, it's difficult for them to eat. They have so many things. For radiotherapy, we don't even talk about it because we don't have it. So if a person does have it and needs these three items, you can't basically have these three items in the Gambia. They're only obviously available outside, especially when it comes to the radiotherapy. So it makes it really, really very, very difficult and very challenging. Again, emphasizing the need for prevention.
And just one final and general question, because you people are more to, about brain issues.
Yes.
What can communities do to better support women, or let me say people? Because I hear men also can get breast cancer, men and women who get breast cancer.
Okay, I think the best support will be to help communities prevent it. And then those who also help communities identify it early on its track, because that's when it can be stopped. I have friends, relatives who survived breast cancer and who are alive today. Then as a community, Gambia has really tried in providing funding for drugs for their country. And in the referral system, there are good things about the Gambian health system. I come from Nigeria, and I see that there are a lot of good things I will go back to tell my country about. In Nigeria, if you are referred from one facility to the other, you are on your own. In Gambia, from the primary health center, where you are referred to the secondary, to the tertiary, the state takes you from everywhere to everywhere. So there are a lot of good things, So, and those are the things that if they are able to identify them on time at the primary center, they are able to be referred to the secondary, and they are taken to the tertiary, and then the intervention starts early. So we need to teach communities how to identify these things. Many times when people come to us with epilepsy, they would have gone everywhere, including going to marabouts in Senegal. I wonder whether there are no marabouts in Gambia. So they go everywhere. Then they ultimately come when things are very bad.
Yeah.
So I think we need to talk to our people. Our people need to understand that our healthcare system works. They need to believe in the healthcare system because it works. And when they're able to identify these things and come to the community, the hospitals, and they are referred to the right places, the government has done a lot. The World Bank has done a lot to train our doctors, to put capacity in our health system. And the likelihood of surviving when you come early at grade 1 cancer is very high. But when you come with very bad cancers, with distant metastases, it has spread everywhere, blood is low, this is low. In fact, many times it's so bad that nobody bothers to remove the breast, because of what use is it removing the breast. So that's a very bad case. So I think we can actually educate the communities to identify these things on time, to take up lifestyles that stop this disease coming.
Dr. Jabang?
Yes.
Anything to add to that?
Yes. Support groups would be very good. And now we are having some of them, but we just need to have more of them, where you have support groups that will cause do a lot of awareness. And also, I think that awareness must have to be a continuous process. And I heard you in your introduction talk about that. Pink October is really when we do more awareness than ever, but this should just be continued, yes, in the community. And once the people know, the women are taught, the teenagers are taught to be able to examine their breast. And once they know how it feels, the normal breast, once there's an abnormality, they will be able to know. And they will make the necessary alarm. They will hear, I had it On Coffee Time, they were talking about if you feel that you have a lump in your breast, you should go to so and so and so. And she will come home and say, Mom, I feel that something is here. Even if the mother doesn't, is not, let's say, literate and doesn't listen to this, but because she had the announcement somewhere, that will trigger for her to have a consultation. Yeah.
You're with Coffee Time with Peter Gomez on Monday, the 13th of October, 2025. And with us are two doctors, Dr. Ndubisi, the one in the middle, and Dr. Jabang. They are neurosurgeons. And we are now going to veer into their field of work. Dr. Ndubisi, epilepsy is misunderstood in this country. Can you tell us what it is and how it affects daily life?
Well, epilepsy, described for a common person, a non-medical person, it's a convulsive seizure disorder. That's what they use. So people call it CRIS, but CRIS per se does not refer to epilepsy. It's not synonymous to epilepsy. Epilepsy is deeper.
Oh,
epilepsy is
CRIS is something else.
CRIS is just one event.
Okay.
If you have a hypoglycemia, you can have a CRIS.
Doctors and big words.
That CRIS, that CRIS is not an epilepsy because we know what caused the CRIS. The CRIS is hypoglycemia. So actually, epilepsy talks to CRIS happening again and being likely to happen again because its origin is in the brain. Therefore, when you have CRIS occurring from places outside the brain, they are not actually an epilepsy. There are things we can correct. I've told you one, hypoglycemia. In fact, when you have a convulsion because you fell down and you hit your head on the table and then you have a bleed in your brain and that first convulsion you are having, we know the cause. The cause is that you fell down and therefore that's not an epilepsy. That is because there is blood in the brain. But usually, when the blood is resolved and there's a scar on that brain tissue, and that brain tissue continues to misbehave and fire abnormally, then the epilepsy has started. So when you come in the first time, you have blood in your brain, you are not my patient. You go to Jaban. Jaban will drain the blood. But subsequently, you go home 6 months later, you are now falling anywhere. It's very embarrassing. They bring you to me when you're embarrassed. My business is to take away the embarrassment. So that embarrassment, that social embarrassment that comes with an injury to the brain is what we refer to epilepsy. Having said that, there is a caveat that says when you've had a first convulsion and we cannot explain why, then, and the doctor, me, seeing you, I now know that you can have another convulsion. Just because I have come, I don't wait for the next convulsion. I know that another one will come because the first one is unexplained. Then I can label you to be epileptic. And then, so that's what epilepsy is. So epilepsy is multiple convulsions. Now, let me also say the next issue is, it's not true that every time that people have epilepsy that they fall down. There are other types of epilepsies. For instance, there's the one they call the absence, spelled absence, and is a French word. That one, the children are just looking at you, they sit down, they become blank. That blankness is an epilepsy. There are other ones that are very brief. For instance, we have the infantile spasm. It just comes on and shakes the child and leaves the child. In fact, the ones that shake very little and leaves you standing are more damaging to the brains than the one that throws you down and you're rolling everywhere. The dramatic ones don't really harm the brain as much. It is the non-dramatic ones that gives more damage to the brain. And you see the children, they are growing, their head is not growing because the brain is not growing. So that's what epilepsy entails.
Okay. And well, he's used a lot of big words. In the Gambian context, if you were to explain epilepsy to somebody who's not been to school, how do you explain that to them, Dr. Jabang?
Yes, so he talked about CRIS, which simply is somebody who falls down. It has various stages. So initially, some would start by, say, just shouting, and they become stiff, and then they fall, and then they start to jack, the big common one that he talked about, and they jack and jack and jack for a certain period of time. During the jacking process, they can obviously be drooling saliva, they can bite their tongue, they can have very deep breathing, and then after that then stops and they lie down and they go unconscious, they sleep. And then later on they wake up.
They just sleep, they don't die?
They would sleep, they would not die.
Okay.
Of course, there is the other concept we call SUDEP, sudden unexpected death in epilepsy. It could happen during the convulsive period. Your heart arrests, and that's it. You are gone. So they do happen, and probably Dr. Ndubusi would talk on that a bit more. But that is what we then call the crease. Yeah, that is what we will call the seizure, and that's what we see. Of course, Dr. Ndubusi talked about others that, just sitting like this and obviously go blank. And sometimes you can have a partial seizure where it's one part of your one side. It could even be, just the hand that is going that way. Yeah, and afterwards it stops. That's a partial seizure where you don't lose your consciousness. Yes, you are conscious of your environment, but you are seizing. Again, how do we explain that to the layperson to understand? So Dr. Ndubusi talked about a disease coming from the brain. So we know in simple terms, for me to move my hand, okay, it's very simple for you. I'll just do that. But what has happened?
Let me see whether mine will.
Yes, it has gone. But what has happened? It's that first you want it, and information is sent to the brain that we want to move the hand, the right hand for that matter. That information travels through a form of an electric current that goes to that part of the brain at the exact area where the hand is represented in its movement. It then fires, and it comes through the nerves, come to the muscle, the nerves innervate the muscles, and then the muscles contract. And when they contract, I'm able to do this. So if you have, like Dr. Ndubu said earlier on, like an injury to the brain, it then just becomes like you have an electric wiring where you scrape off the coating around.
The insulation.
Exactly. And here and there it sparks. So once that sparks, it then sends a general wave around, and that wave just comes entirely in your body, and then it becomes something that you are not controlling. Because initially I can control. I will say, I want to move my hand. The signal is sent over there, and then it comes. But then here is already a distortion where a signal is just bursts out and sent. And that's how people then fall down and obviously have epilepsy. Yeah.
Tell us, when one is epileptic, what goes on in the brain when you are in the process of seizures? I think he just started, talking about that.
As a neurologist, if you take me into that, I may go very deep. But let me try to stay very superficial. At every time the body tries to generate electricity to power the muscle, there's a mechanism in the brain that stops the body from generating too much current.
Okay.
Therefore, the body generates, let's say, 5 millivolts, and that's what it needs to move them. If it produces 6, the body produces something to mop up the extra one. It doesn't want it. When this mechanism of producing what counters the necessary current we need is exceeded or defeated or removed, we call it the inhibitory pathway. When they are removed, then the body tends to produce too much current, and those too much current are sent to the muscles, and the muscles begin to misbehave. So it is this problem in the brain that's not a spiritual problem. From all we've said, it's very physical. And we can also get into the reason why these things happen. It is this ability of the body to generate excess current, and the body's inability to mop up excess current. This imbalance is what gives you too much current going either to one part of the body or to both parts of the body. So this is what epilepsy is all about.
Dr. Jabang, I said at the beginning of this conversation on epilepsy that epilepsy is is it an illness, is it a condition that is misunderstood in this country? But what are some of the myths or misconceptions associated with the disease in the Gambia?
Yes, so thanks for that question. The Gambia is not an isolation. Gambia is, again, with other countries. But I'll come back to the Gambia. It will interest you to note I was part of a study by the Epilepsy Africa Alliance, a group we are part of. And they did a study to find out the names of epilepsy in almost all the local languages within Africa. This obviously include Arabic, because we have our other colleagues from Egypt, from the other part. local languages, and to our utmost dismay. So we were obviously given, like in Wolof, it's Danurab.
Yes.
To our utmost dismay, more than 90% of the terms that are referred to epilepsy was something referring to a gene, or referring to a spirit, or referring to an evil kind of power. So already the name, like in the Gambia we say Danurab, that name alone has already stigmatized it. And then once people have it, then they are thinking of so many things. The first thing they say, it's not, you don't need to go to the doctor. This is something that is spiritual. So one, the name alone is there, and it's very damaging. But two, we have so many things in the Gambia where people even think that epilepsy can actually be transmitted. And that is so bad. People say
it's not contagious.
Oh, yes, exactly. It's not contagious. Dr. Dubusi will emphasize that a bit more. But it's not contagious. And the reason why that is bad is because people who have an epilepsy and fall in the fire, and I'm not telling you about stories, but I'm telling you about realities, that at some point we almost wanted to publish a paper on burns in epilepsy. Because those who are born from having an epileptic seizure and fall in the fire, they come with very terrible burns. Why? Because they fall over there and nobody touches them. The families don't touch them. And before people come around and help them,
even if they are close enough to be able to drag them out of this fire,
they don't touch them. Wow. And that's all because we have all this concept of that epilepsy is contagious, epilepsy is satanic, epilepsy is all that. So they run away from them. And some of the people, they also just leave them like that. They don't go for care. They don't do. So we see quite a lot of people really in the Gambia. And I'm sure during the 2 years that Dr. Ndubusi have been here, looking at really the pediatric epilepsy, he would tell you also more stories that he has seen.
We'll ask about his opinion on myths and misconceptions. You spoke about the disease, the condition not being transferable, but a lot of people say when an epileptic person falls down and they start producing foam, exactly. If you touch that, then you become epileptic immediately yourself.
Yeah. So no, you don't. You don't. In fact, that the funny part, I was so when I was invited at your congregation, to go and talk about epilepsy, and we were talking about it, and somebody said also he even had that. Well, somebody was saying that if you have an epileptic patient and he produced some bad air, and you inhale that, you're going to have it. So it's not.
What are some of the outrageous things you're hearing about epilepsy in this country?
Well, I wouldn't say they're outrageous because where I'm coming from is the same story. So they are not out of this world. But I have also practiced abroad, and I know that they see epilepsy as epilepsy. But here, in Africa, in Nigeria, they also believe that the spittle touches you, you contact it. So a driver was driving, and somebody in the car had an epilepsy, and while he was having the generalized tonic, the one that produced a lot of spit, of course, the driver jumped out of the moving car, and it was a disaster.
The driver himself?
The driver jumped out of his moving car, and I'm telling you, it ended as a disaster.
Of course.
Now, there are other issues. So they believe that it's the spittle. And so we ask questions to counter that. It's not true. Because, in fact, those epileptic patients, when they eat in their homes, people refuse to wash their plates. People refuse to wash their spoon. They are isolated in their homes. Because of these things, they feel less like human beings. When they talk to us, the adolescents, when they talk to us, you hold your tears because they tell you, why am I alive? Even my father runs from me. I have a different room. All my brothers stay in one room. I can't even go there. So I heard among one of the tribes here that they believe that when people contact epilepsy, when the woman is pregnant and she baths outside. I've heard all sorts of things. I've heard a lot of stories. That's what different tribes here believe in. They say a lot of things. And so the truth is that if it were true that people contact epilepsy by spittle, touching you or by touching the person, I should be the most epileptic person in this world.
Yes.
I should be convulsing in snaps and talking to you. But I don't convulse. They fall in my hands. They fall on top of me. I carried them. In fact, a mother who came to my clinic last week brought her child who was convulsing, and she was also convulsing by the side. So I was taking care of the mother. I was taking care of the child. And I don't have it. You ask yourself, husbands who are married to women who convulse, live with them, give birth to children with them, but when they are convulsing, they run away. If epilepsy is contacted by spit touching your skin, oh my brother, we don't need to speak more.
The husband should have
don't say more. Don't say more, because there will be children listening to this program. So, but for Christ's sake, we do things and we don't push on what we do. Because if I believe in something and that thing is wrong, and I continue to say the same thing, and I continue to do the same thing, at a point, maturity shows that I should be able to ask myself fundamental questions. And ask myself, this thing I've been running from, does it actually kill? When I came to Gambia, I remember one night I saw Kankura. By 12 midnight, I was coming back from the house. Kankura had 2 knives. And as an old man, I ran for my life because in Nigeria. And it took people to convince me that the Kankura doesn't use the knife on human beings. But now, I now see Kankura and I don't run. Because I've asked myself, if they are allowed to move with 2 knives and the police has not arrested them, then they are not harmful. We need to bring in critical thoughts into what we do. Then another thing I want to say is that when your child is sick and you run to a marabout, the marabouts come to my clinic from Senegal with their children who have epilepsy. How can you be going to somebody who is consulting somebody? We need to balance these things. So let me just say, I always say it everywhere I go. It is not transmitted that way. But when you want to talk about how epilepsy is generated, how it's inherited, we talk about sodium-gated channels, calcium-gated channels. We talk about them and we talk to you and you understand why some families have a lot of people who have epilepsy, and even the people who don't have epilepsy give birth to children who have epilepsy, and we tell you the drug to use, and the drugs are free in Edward Francis.
We are interested in that kind of conversation. How is epilepsy passed on, or how is it acquired?
Let me just say briefly.
Yes.
The first thing and the most common thing that causes epilepsy is birth injury. When mothers give birth to children and the children stay long in the this before coming out, and they have brain injury. Those brain injuries form scars. That means those wires become unearthed, and then later on in life, those places begin to misfire because they are now made of fibrous tissues, and those fibrous tissues have a higher firing rate than the normal cells. That is what causes more than 50% of the epilepsies we have. The other way why people contact epilepsy is because they were born preterm, and so the thalamus suffers.
Preterm is premature.
Okay. So they were born premature, some 28 weeks, 29 weeks. So as far as science continues to deepen all over the world, and we're rescuing more children, and they tend to have periventricular leukemalacia, they begin to have a lot of funny things in the brain. Those things cause sclerosis of the thalamus, and those thalami sclerosis will give us generalized epilepsy later in life. Now, let's leave the newborn. There are families whose mothers are convulsing. Those mothers they are not convulsing because the mother has a brain injury. The mother is convulsing because in the family, they are used to convulsing. Now, she has an inherent sodium-gated disorder or a calcium-gated disorder, which they are passing from family to family. Now, let's not get deeper than that. So if that is what you are having, you find out that even your children will go out and they will continue to have it because the gene is defective. The gene can be balanced. If you are coming from a place where there is such defect, you can marry people that do not have such defects. You tend to come together and it tends to balance out that gene, because some of the children will get the healthy gene from the father and unhealthy gene from the mother. And when that happens, you tend to see that as generations go further, these things begin to dissipate because of the marriage. But now, when you now have a society where people promote consanguinity, where cousins who have epilepsy are marrying cousins who have epilepsy, it is disaster. So there are things we need to work on in a society. We need to balance genes. And when you are balancing genes, you are taking away some of these inherited disorders and they're fizzling away. So these are the ways that epilepsy come up. Epilepsy can also come from later in life when people begin to have head injury, especially boys. When they go to play football, they hit their head on the floor, they pass out, and they wake up, and when they get up, all the boys there will have enter an oath. Nobody will tell the parents. And the child lives, but that is a scar. And that scar later becomes a problem. Accidents, bleed in the brain, those who are hemophiliacs, and all these other things. So a lot of issues come up as children are growing that brings trauma. And all those trauma, those things that the brain has suffered later on in life, they will begin to give us problems. There are other things. Children can also inherit some other conditions that can give you epilepsy. For instance, you can have somebody who have some kind of rashes on the face, some kind of black spots on the back. Those things, when you see them, they also have effect on the brain because the brain develops along with the skin. They are all ectodermal tissues. Now, there are other issues that can also give you epilepsy. Things
I'm looking at my palm. I have a black spot. I have a black spot in my palm.
It has to be up to 2 to 5 centimeters, a big patch, and it's called the coffee or lace spot on your back. Now, they also have problem with their eye. No, it's a long story. So, and those ones are his own case. That's where surgery comes into epilepsy management. Now, there are other issues like autism. Autism is on the increase. Autistic children, people who have no feeling, they are not empathic, they don't have language development, they like to stay on their own. They are now having more of it worldwide. And no, when children have that, they tend to have more epilepsy. So there are other things. Rett syndrome. I've seen Rett syndrome. I didn't see it in Nigeria. I've seen Asperger's syndrome here. I don't
we
have
Rett syndrome here.
You have Rett syndrome here. You have Asperger's syndrome.
What's Rett syndrome?
It's a long story. It's not. This program may not be able to carry.
Is it what your eyes
are
red?
No. Those ones. By the time Rett syndrome, by the time they begin to get to about 8-9 years, they begin to squeeze and turn, and their body begins to take funny shapes, and they don't walk straight, and they tend to have chorea and all those. It's a deforming illness. And I've seen it in a consanguineous marriage. I've seen Asperger syndrome, which I've not seen in Nigeria. I've been looking for Asperger. I came here.
So close relative marriages can have serious repercussions on children.
It sustains genetic diseases. So having said that, so these are some of them, not all. If you ask Zaban, he will tell you more. So,
which brings us to, you use the word, epilepsy management, treatment. Dr. Jabang, if you can just...
Yes, so we can't talk about epilepsy treatment today if we don't mention some people. We mention FESGAM. FESGAM is the Foundation for Epilepsy and Stigma Support. It's headed by Adama Jalojane in the UK. And they started about 3 years ago, and they've done quite a lot. So why is FESGAM important? Because they were the first that have brought EEG services. For you to actually diagnose the electrical activities of the brain, you need a machine called an EEG. Yes. Even though we say epilepsy is a clinical diagnosis, meaning that somebody has an unprovoked seizure that happened once and twice and that, or the other things that Dr. Ndubusi mentioned, he has it once, but you examine him and see that he has a risk of having another one. You can easily say he's got a seizure. But we never had the diagnostics before, so it was FESGAM that collaborated with Tele-EEG in the UK, and that's when we then have the first EEG machine in the country. And for EEG, it takes people that are really well trained. In the country, I think we have only Dr. Ndubusi, and we are lucky to have him here, who is able to interpret it. So then before then, we send them to the UK, and then we get the interpretations, and the interpretations come. Also, the second reason why I want to thank FESGAM is because they contacted with Roe Foundation, who are able to provide them with some medications, which is called levetiracetam, which is very, very expensive. Coming back to your question, in terms of management, the first thing is that we have moved as a country. Initially when I came here, I was a neurosurgeon. When I was training in Dakar, I had a special interest in epilepsy. Epilepsy really is for the neurologist. In our training, it's usually the neurologists that do it. But now, there are some parts of it that are done by the neurosurgeons. Like, for instance, some kind of drug-resistant epilepsy that are operated by neurosurgeons. And we had the first of its kind, which is done by the American team, the Brigham and Women's Hospital, when they came here. And they operated on one patient, and we hope that is going to continue. So when I was in Dakar studying, I had to now have a special interest in epilepsy because I don't have a neurologist back home. And when I came back, we start to manage patients with epilepsy. There are medications that are available. So carbamazepine we know, sodium valproate we know, all these medications are available. Of course, sometimes you go to the hospital and you don't have it, but you need to go probably maybe in the private and buy it. But like Dr. Ndubusi is saying, with these collaborations, the hospital is able to really have some medication. And sometimes they have it too, but they have to ration it. The good thing is that medications are available. They may be within the hospital and you'll be lucky to have them. Or you may have to buy them from a private pharmacy, but the medications are available and they are effective. Also, the good thing we have is that now we have a pediatric neurologist. We have also an adult neurologist who have all come through the postgraduate training. And these are all people with very advanced knowledge when it comes to epilepsy care. And they can even help us, diagnose some of the other subtle forms of epilepsy and be able to treat them. So I could say that the management is available. Yes, you just need to get to the right place to get it.
I'm sure we can't say everything about epilepsy in the limited time that we have here. But we spoke earlier about people falling, having seizures. What should someone do when they witness, an epileptic person, in a seizure in public?
Okay, thank you very much. It's very necessary. Number one is do not be afraid. Okay. 90% of those who convulse don't die.
At least you've calmed me down.
Don't be afraid. Nothing is happening. Even when they are very violent and kicking everything, he doesn't intend to kick you. So don't retaliate. We want to save the person. Number one. Number two, the head must be flat at the same level with the body. Don't sit him down because the head will be up and his body will be down. The body wants to send blood to the brain. Number three, remove him from any harm. If you're in the kitchen, you shouldn't do resuscitation in the kitchen because knife can fall on top of two of you and there'll be trouble. So that's not so. Remove him from the harmful environment. Keep the place clear. Number three, turn him to his side and ensure that he's lying on his side, like how you lie with your two hands by your... Yeah. You must do that.
It could be left, it could be right.
Anyone, okay. But preferably if you have a choice, left. But if he has sustained an injury on his left part, then the left part should be on top, then you be on the right. The most important thing why we are doing that is to make sure that he does not, his spit and his tongue doesn't go to block his airway, because that's what kills 90% of those who die. So we want to make sure that...
you hear people saying they swallow their tongue.
No, you can't swallow it, but actually the tongue can fall backwards and block your airway. Therefore, and if the person is not breathing from the nose, the person may have a problem. So you must turn them in such a way that they are drooling saliva out, so that the saliva is coming out. As the saliva is coming out, air can also be going in. Even when they are stiffened, which is the worst type that can happen to them, you hear them making the little at the end of that, he takes one small breath. He's able to keep the brain going so that the brain doesn't suffer much harm. If you do these things, then you will find out that the person will recover from that. And once he recovers from that, you can take him further to us. If he doesn't, you can also move him lying down to a health facility where some injections can be given, and then in a few seconds it will be broken. So this is what you need to do at the site where it has happened. We can move them even convulsing, but they must be lying down. Please don't sit them up because the brain takes more heat, and then bring them to the facility where we can continue to manage them. So it's a very simple thing.
Fantastic. Thank you very much, Dr. Ndubisi. You've been very useful this morning. And Dr. Jabang, and how do we get the word out more effectively? It's one thing to come on a radio program here, but at community level, you have people who are more influential than a broadcaster either on radio or television.
Yeah, that's very true. So the first GAM did quite a lot of work, really. We had some trainings, especially. We started a project that hopefully we are going to continue, where we're going to get to the community. So we got most of all the hospitals, kind of the health centers, major health centers. We got people around. So what we want to do, working with the Ministry of Health, and that was also something that really the Ministry of Health played a very great role. We are now trying to get centers in all the hospitals. With the specialists that we now have, we intend to now go around. Yes. One of the other ways, of course, that we want to do that, anybody can do is, of course, the support groups going around sensitizing the people. Just the awareness campaign. There's so many papers that have been written out there about the perception of epilepsy in low and middle income countries, and it's basically the same. The way we think about it here is the way they think about it in Asia and all that. So we are hoping that once we are able to get to these hospitals, first of all, they've already had the training. Now it's just to go and reinforce what they have and try to see if they can build within their training system, build within their own system some advocacy. The Ministry of Health has a whole department that is responsible for health promotion and all that. We will see how best obviously to work with them and just make sure that that message goes out. With regards to epilepsy, the most important thing is awareness, in my opinion.
Okay.
That is the most important thing.
Okay.
Because very few of them would need surgical intervention. Most of them, with the right medication, you can get 70% of all epileptic patients, free from having seizures.
Fantastic. Yeah. And in terms of prevalence, how serious is epilepsy in the Gambia?
Oh yes, it is. It is. I don't have the exact figures here, but it is, and even it goes to back what Dr. Ndubuisi was saying, because of our, we were talking about, consanguinity, which obviously is a risk factor of really producing a lot of neurologic diseases, not only epilepsy, but we have quite a lot of epilepsy. Yeah, the neurology clinic, I think most of them really.
On average, how many?
Yes.
It's the busiest clinic in Edward Francis.
Your clinic
is the biggest clinic in Edward Francis, and the biggest thing we treat is epilepsy. 80% of our patients are epileptic.
Wow.
And then, so epilepsy is a big thing here. In the whole of West Africa, the average study they've been getting is 3 to 4% of the general population being epileptic, 4 to 5% in children. And then over time, some of the children die off. So general population is said to be 3 to 4%. In America and China and India is 1%. That means we carry 3 times the load of other countries are carrying. Now, we do not have the data for here, but we know that poverty in all the countries of the world where there's a lot of poverty, in Malaysia, in Singapore, in Bangladesh, in West Africa, Sub-Saharan Africa, we have a higher load, and it's thought to be due to worm infection, malnutrition. And so these things are thought to promote worm cyst in the brain, and then those things finally begin to fire and begin to give us epilepsy. So that's what we're having here. So, but it's something that can be stopped by addressing how women deliver, addressing what is done for the child in the first few minutes of life, addressing marriage issues, addressing, if we can address this way, we'll be able to sort out a lot of the problem we have. Because there's even another problem in Gambia.
Which is?
The problem is you have children who have what we call the Landau-Kleffner syndrome. It's more common here than it is in most West African countries.
And what's that?
That's the children who convulse for the first time and they stop talking. And if you don't do anything about it, they'll never talk again. So it's very common here. We've had about 20 patients with such. And so we've been able to reverse speech in all 20.
Well done.
But we have another one that has just come in, who is coming from Senegal. We don't know whether we can reverse because it's been a long time. So you find out that there's also, maybe because of the genetic problem we're having here, there's also a special problem here. So, but we believe that if we all can join hands, the influential people in community, the teachers in our mosque and our churches, if we all can agree.
That's why I talked about community leaders.
If we all can agree, this is a very, very solvable problem. We just need one politician who can become the center, of this drive, and say, let us call a meeting of this, and all chairmen of all this, and we all come together. Even the marabouts, they need to come. They need to submit that this thing they are telling people that epilepsy is not treated in hospitals, they don't need to say it again, because that's what they tell these people. And many of them who become epilepsy free tell me, our marabouts told us that this does not go to the hospital. We are surprised that this can be taken off. And they always go back and bring 4 people from the community to you. But you can see that self-referral. It's a very slow way of moving. We need to move faster so we can help more people, because some people's brain are being damaged as we are having this discussion.
On that very strong point, we end this conversation. Dr. Ndubuisi, I hope we can have you back here very soon to talk about other issues you haven't been able to cover this morning. Dr. Jabang, thank you so very much, and good luck to two of you. Later on, we'll be talking about mental health. You're with Coffee Time with Peter Gomez.
Jar Oil. The company have filling stations across the country, and our rates are relatively cheaper than anyone else across the country. Jar Oil is the biggest producer and distributor of cement in the country with the most competitive prices in the market.
Axila jam si Wave.
Yow Ablaye, yow lu tax doo dee dégg lu tax mënuloo jël moto nga andil ma xaalis. Hello? Kan lay waxal?
Bisul mu fine.
What?
Bisul mu fine.
Oh, yes!
Wave Axina Gambia. Deposit and withdraw money, pay bills and buy mobile credit without fees. Transfer money wherever in the country for only 1% fee. At Wave, Bisul mu fine. Wave, your money is yours.